Today's session is one of our joint venture programs with European Renal Association, roundtable discussion on management of HSP nephritis. What can the adult nephrologist learn from the pediatric experience? This session, Dr. Louise Oni will be our speaker, and it will be moderated by Professor Olivia Boyer from Department of Pediatric Nephrology, Necker Infants Malade Hospital, Laboratory of Hereditary Kidney Disease, Université de Paris in France. Our panelists are Professor Rosanna Coppo, Fondazione Risera Molinetti, Regina Margherita Hospital, Turin, Italy, and Dr. Emily McQuarrie, Chair of the Scottish Renal Biopsy Registry, Consultant Nephrologist, Glasgow Renal and Transplant Unit, Queen Elizabeth University Hospital, Glasgow, UK, and Professor Jurgen Floege from Division of Nephrology, RWTH, Aachen University Hospital, Aachen, Germany. So, welcome, Louise, and the screen is yours now.
Okay, so thank you for the introduction. Over the next 20 minutes or so, I'm going to be presenting about the management of Henoch Schoenline Purpura nephritis, and then we're going to have an expert panel discussion focused around what the adult nephrologist might be able to learn from the pediatric experience. So I'm Louise Oni, a pediatric nephrologist based in Liverpool in the United Kingdom, and hopefully we'll be able to educate you over the next kind of 45 minutes. Just to outline the talk, in the next kind of 20 minutes, we'll focus on a bit of background on Henoch Schoenline Purpura, also known as immunoglobulin A vasculitis, and then focusing on the renal involvement. Throughout, we'll focus on differences between adult and childhood disease, and then the discussion will be around how the adult nephrologist might be able to learn from what we do in pediatric practice. So just to start with, by saying that a number of years ago now, the international community proposed that we change the name from Henoch Schoenline Purpura to immunoglobulin A vasculitis, just to better illustrate the biology that might be going on in this disease. But actually, in current practice, the names are both used interchangeably, and throughout the talk, I will be using the names interchangeably. So Henoch Schoenline Purpura, or HSP, or IgA vasculitis. So this is a disease that is much more common in children. In fact, about 70% of all the disease will present in the pediatric population, with only about 30% of patients presenting during adult years. And as you can see from this graph here, which looked here the number of patients, and this is the childhood years. This was a study that looked at all inflammatory diseases within children, and we can see that the top line here represents Henoch Schoenline Purpura, and you can see quite clearly that this is by far the most common inflammatory disease that we see in children, and it has a peak age of incidence in the kind of early childhood years, so around about 5 to 9 years old. And it's unusual in infancy, and then it tails off in the teenage years, coming into the adult age. And in children, we see a slight predominance in the male gender, so the male to female ratio is about 1.5 to 1, whereas in adults that difference is not seen as much, and it's almost equal in gender distribution. With regards to the epidemiology, you can see in these two pie charts here on the left, we have childhood vasculitis, and here on the right we have adult vasculitis. And you can see that when we divide the different types of vasculitis in children that we see, by far the most common is immunoglobulin A vasculitis. And this is in stark contrast to adult disease, where actually it's a rare condition and only takes up a small proportion of all the vasculitis that our adult colleagues deal with. So we have internationally agreed classification criteria that distinguish Henoch Schoenline Purpura from different types of vasculitis, and these are generally used for diagnostic purposes as well. They rely on the presence of this very characteristic purpuric rash, which is predominantly on the lower legs, together with any one of the following criteria, so either abdominal pain, histopathology that demonstrates IgA deposition, arthritis or arthralgia, or renal involvement. And together, these give a very good sensitivity and specificity in distinguishing it from other types of vasculitis. And so the diagnosis of HSP is usually made from clinical findings. If we look at environmental triggers, there are a number of reports that have looked at different triggers in children. This was an extremely large study in over 16,000 patients from Japan, and it demonstrated very clearly the seasonal variation that we see with this disease. And here you can see in this graph the number of HSP patients, and this is the months of the year. And you can see this nice distribution with peaks over the winter months and actually a lower incidence over the summer months. And this, they found in this group that this correlated with specific respiratory and also gut viruses. And importantly, when they went to subdivide the patients into the age, so even within childhood, they divided the patients into infants, early childhood, middle childhood, and adolescence. And you can see very clear differences in the viral triggers shown here in the bold print that were statistically significantly associated with Henoch Schoenline Purpura. And in particular, the younger children had viruses that we commonly see, such as HSV and influenza, whereas the older children had viruses such as rotavirus or bocavirus. And so even within childhood populations, we may be seeing different triggers depending on the age of presentation. We also know that other triggers can precipitate the disease, so it's often associated with ear, nose and throat infections, and in fact it's well recognised that recurrent tonsillitis is seen in about a third of the patients. And some papers have also demonstrated clear associations with poor dental hygiene, and this is probably linked to a chronic inflammatory state of having dental caries and that precipitating IgA to be produced from the oral cavity. Certain drugs and also malignancy and vaccines have been associated with triggering the disease, but these are actually extremely rare in children and much more common in the adult population. And in fact, malignancy is predominantly in the GI tract in the adult reports, and where they've shown an association with triggering the disease. If we look at what might be causing the actual disease, we see that it's usually a production of abnormal IgA, and this IgA usually comes from the oral cavity or from the gut. And this is because immunoglobulin A is your first line of defense in your mucosal secretions. And so if you have an invading pathogen, your IgA will be produced in normal individuals. And what's believed to happen in this condition is that the actual IgA that's produced is abnormally produced, and your body therefore produces antibodies against this potential antigen. And the immune system is then unable to clear away this abnormal IgA, and it can deposit both in circulation, but also deposit within the small vessels in both its individual form, but also in its immune complex form with antibodies. And so what we see is characteristically IgA is deposited within the small vessels together with a whole host of inflammatory cells, and very classically we see complement C3. And together this produces the leukocytoclastic small vessel vasculitis that is characteristic of this disease. So what exactly is happening? So within the actual immunoglobulin A molecule, it's believed to be the hinge region of this molecule that's abnormally produced, and it's thought to be the glycosylation of this protein, and it produces certain areas which such as GalNAc, which residues are able to promote an immune response and constitute an antigen. And some papers have suggested that this is able to directly bind within the mesangial cells, and this might be direct binding from this IgA complex to the mesangial cells that produces the downstream inflammation that we well recognize with this disease. So clinically, what do we see? Well, we see skin involvement with 95% of patients presenting with a rash. We also see that this rash is usually symmetrical. It's usually predominantly on the lower limbs, and it's characteristically a palpable purpura with some petechiae and bruising and skin edema often involved. We also see this triad of other organs involved, which are usually the joints, the gut, and the kidneys. And we see, particularly in children, about 70% will have a non-erosive arthritis or arthralgia. With regards to GI involvement, this can extend from mild abdominal pain to more severe pain, including GI bleeding, which can be life-threatening, and intussusception. In the boys, you can get testicular inflammation, and renal inflammation is actually relatively common, with almost half of the children presenting having some renal involvement at some point of their disease. And it's extremely rare to get other organ involvement, such as neurological or lung involvement, although this is reported within the literature. Interestingly, in the children, we tend to see much more abdominal pain and arthritis, whereas adults very commonly get much more severe renal involvement, and we don't exactly understand why this is. With regards to the clinical course, the majority of patients, it will be an acute illness and it will last less than a month. And actually it has a very good outcome, with most patients fully resolving within 3 months. And in fact, within 2 years, 94% of patients would have made a complete and absolute recovery. The only long-term morbidity really is associated with the renal inflammation, and 1 to 2% of children will progress to end-stage renal failure. And this is much higher in adult cohorts, where over 12%, sometimes up to 30%, will progress to end-stage renal failure. And we know if we subdivide patients into those that are at higher risk, the patients who present with severe nephrotic or nephritic involvement, about 20% in 5 years will progress to end-stage renal failure. And from the literature, we can see that in general, adults have a lower renal function at presentation. They generally have more edema and more clinical signs of nephrotic syndrome and more hypertension. And children tend to have isolated heavy proteinuria as their presenting feature. So what do? It's generally recognised that all patients who present with Henoch Schoenline Purpura should undergo a period of renal monitoring for at least 6 months. And this usually depends on their urine being screened. And some years ago now, we published what we do in our practice as an example. And importantly, we stratify patients as to whether they have no proteinuria or proteinuria, because we know that if you have protein in your urine, you're more at risk of having significant renal inflammation. And so we see those patients with a normal urine less frequently compared to those patients who have proteinuria, where we see them more often to be able to try and pick up any significant renal inflammation. And when we looked at our data, we found that a normal urine on day 7 was actually a really good predictor of a normal outcome, with a negative predictive ratio of 97%. And more recently, this has been replicated by a bigger cohort of patients, and they also validated this finding that a normal urine at day 7 is a good predictor of a normal outcome. But at the moment, it's still agreed internationally that at least 6 months monitoring should take place, because there are the occasional patients who will have a normal urine at day 7 who can go on to get significant renal inflammation. So when would we do a renal biopsy in those who do undergo renal monitoring and have renal inflammation? Well, until recently, there has been no international consensus on when to do this, when to do a renal biopsy. The SHARE initiative, which was a European group predominantly with pediatric rheumatologists, have recently reviewed all of the literature and come up with consensus-based recommendations based on the literature. And they've included criteria for when to do a renal biopsy in children with IgA vasculitis. And they concluded that a biopsy should be done if a patient has severe proteinuria, defined as a urine protein to creatinine ratio of greater than 250 milligrams per millimole for at least 4 weeks. Although a shorter duration of severe proteinuria could also be a relative indication for a biopsy, or if a patient had persistent moderate proteinuria with a urine protein to creatinine ratio of 100 to 250 milligrams per millimole, or if they had impaired GFR at any point. And at the moment, these aren't in clinical practice, but it may be that this is the first step for us beginning to achieve an international agreement on when we should biopsy patients with renal inflammation in this disease. So once we do a biopsy, we then would classify the histology, and at the moment there's no agreement on the optimal reporting of the histology, but most hospitals are using the ISKDC classification shown here in this table, which grades the histological features from grade 1 to grade 6, as you can see within the description. There has been some publications looking at semi-quantitative scores similar to the IgA nephropathy classification, which include activity, chronicity, and tubulointerstitial features, and these may be superior in predicting outcomes. And what we see within the literature is that actually adults with this disease tend to have more grade 3A disease, so more focal disease, whereas children having a renal biopsy will often have more diffuse features on their histology, but tend to also have grade 3 histological classification. And it's well recognised that adults will have more evidence of renal chronicity and damage in their initial biopsy compared to children, where we often see very little chronicity. So with regards to management, we know at the moment that patients who present with IgA vasculitis should all have 6 months renal monitoring to check for renal inflammation. And there have been studies looking at early treatment in all patients presenting with IgA vasculitis to try and prevent renal inflammation at the earliest opportunity. And actually these studies have been negative, and at the moment there's no evidence that early treatment with corticosteroids will prevent patients getting renal inflammation. And so patients do not receive any treatment prior to the histological analysis at the current in current practice. And so once patients have histologically biopsy-proven disease, we then need to consider immunosuppression, but we don't really know which immunosuppressive agent is best. And we have this massive predicament of a lot of patients presenting where the majority will have a very good outcome. Some of them will get some renal inflammation, but may or may not get better. And then this 1 to 2% or even higher in adults will progress to irreversible end-stage renal failure. And this makes it difficult because we need to balance which patients warrant treatment against those who are likely to have a complete and full recovery. Current evidence-based guidelines are few, and generally clinicians are using treatment based on the clinical severity of the disease, so whether they have impaired renal function or nephrotic features, together with the histological findings. When KDIGO published their clinical practice guidelines on glomerulonephritis, we saw that they suggested for Henoch Schoenline Purpura that treatment started with angiotensin receptor inhibitors or angiotensin receptor blockers, and they suggested a trial of ACE inhibition followed by corticosteroids if they hadn't been effective. For crescentic disease, they suggested treatment very similar to IgA nephropathy, and that predominantly used intravenous cyclophosphamide. And they also concluded, like I've mentioned, that there was no evidence for early treatment to try and prevent the onset of nephritis. And within the KDIGO guidelines, they suggested that HSP nephritis in adults should be treated exactly the same as children. And so many of these guidelines here are actually very similar to how we might consider treatment for IgA nephropathy in adults. And I don't think they reflect what's happening clinically. So the SHARE initiative that I've already mentioned looked through all of the literature and came up with consensus guidelines, and they actually recommended very different treatment to the KDIGO recommendations, where they suggested for patients who had mild nephritis to consider early oral prednisolone, those who had moderate disease for, again, prednisolone followed by another agent, so either azathioprine, mycophenolate, or to consider intravenous cyclophosphamide, and then those with more severe disease to receive intravenous methylprednisolone together with cyclophosphamide. But actually these were based on very little data, and the SHARE group acknowledged this within their paper, where they said that there's a severe lack of evidence to support any of the treatments that they've proposed. So what are we doing in the UK? We've recently done a snapshot audit of our clinical practice where we looked at the last 3 patients in each of our paediatric centres. And so we had 35 paediatric patients with biopsy-proven HSP nephritis. And what we found was that across the UK, there were 15 different treatments being used. And these included various combinations of corticosteroids, ACE inhibition, mycophenolate, azathioprine, cyclosporine, tacrolimus, cyclophosphamide, and even rituximab. And so there's massive variation in practice, even within one country. And a few months ago, we held an international workshop to try and see whether we can standardize some of the treatment and also work towards clinical trials. And we established that there's international uncertainty in how we treat this disease, although most people believe it's an immune-mediated disease and warrants immunosuppression of some extent. And importantly, papers have shown that despite monitoring and current immunosuppression, the incidence of end-stage renal failure in IgA vasculitis nephritis has not changed over many decades. And this 1 to 2% in children and higher in adults has remained consistent for many decades, despite us trying different immunosuppressive regimes. And so how could we improve? Well, we have our patients when they first present, and it usually presents acutely with a very striking and obvious rash. And this is often before any renal involvement. And we have this watch and wait approach where we monitor their kidneys for renal inflammation. We know that it's unlikely to be beneficial if we target all patients to try and prevent renal inflammation, because some patients are going to have a really good outcome no matter what we do and don't justify treatment. So maybe we can target those who have early signs of nephritis, perhaps early proteinuria, and this is something that hasn't been reported. or we need to find out how to approach those who have established nephritis with biopsy-proven disease. And at the moment, when the Cochrane group have evaluated our therapies, they've suggested that there's an unknown benefit from any intervention that we use at the moment, predominantly due to small studies where even placebos will look positive. And so what we need is international collaboration where we can undergo a program of trials to evaluate treatments in IgA vasculitis, nephritis, both in those with a well-established disease, but also importantly, perhaps targeting early disease and perhaps considering novel therapies. So what novel treatments could we consider? Well, people have suggested targeting B cells because there's antibodies mediated, driven by the IgA, and there are positive case reports using rituximab, both in adults and in children. These cohorts have mainly consisted of patients who have been resistant to conventional treatment or dependent on steroids. They've wanted to use rituximab as a steroid-sparing agent. However, this is in contrast to the IgA nephropathy trials in rituximab, where they have been negative, and it suggested that actually B-cell depletion doesn't target the glycosylated IgA, and therefore it may not have therapeutic benefit in this cohort of patients. There has been one patient within these B-cell depleted cohorts where ofatumumab has been used, but again, that's only one reported patient. There are no reports of belimumab, which is an anti-B lymphocyte stimulating factor biologic. The other suggestion is, should we target the complement pathway? We often see C3 in association with the IgA deposited within the vessels, and complement inhibitors are being planned in IgA nephropathy trials at the moment, and there are no reports on the use of complement inhibitors in Henoch Schoenline Purpura at this moment. Could we consider targeted release steroids, so using steroids in a slightly different, perhaps more effective way? And there was a trial, positive trial looking at the use of Nefigan, which is an enteric control release formulation of budesonide, targeting the guts, the Peyer's patches. And this has been effective in early IgA nephropathy studies, but we don't yet have any data in IgA vasculitis, nephritis, as to whether this might be useful. And it may be that the IgA in IgA nephropathy is being driven by the gut production of IgA, whereas in IgA vasculitis, particularly in the children, it may be derived from the oral cavity, and therefore Nefigan may not be targeting the correct area for the disease, and we don't know any of this at the moment. So can pediatric practice inform adult nephrology? Well, it's a very common pediatric disease where most pediatricians and pediatric nephrologists will be comfortable making a diagnosis. It's usually made clinically. There is an uncertainty as to whether we should be treating it like IgA nephropathy or whether we should not be treating it like IgA nephropathy. It shares a lot of characteristics in its pathophysiology, but the clinical course is very different, and the biology of IgA vasculitis is not entirely understood because there are very few studies investigating its early pathophysiology. The other question is, should we be treating children and adults the same, as KDIGO suggests? There's even uncertainty in pediatric nephrologists with regard to the optimal treatment, but if adults are at higher risk of end-stage renal failure, then perhaps we need even more aggressive treatment in the adult population compared to children. What is clear that we need is standardized treatment, and some of that is beginning to evolve with more standardized monitoring, biopsy indications, and we need to begin to consider histology reporting and standardizing how we do that on an international basis. But importantly, we need a program of clinical trials, and maybe within a childhood cohort, this would be preferable because we have bigger numbers, we have less comorbidities, we have less other triggers such as malignancy. But we don't know whether the trials in children would inform adult practice because, again, our children are likely to have a much better outcome than adults with the disease. But what is needed is international collaboration. It's a disease that spans various specialities, including our pediatric rheumatology colleagues, but also gastroenterology, sometimes dermatology. And the adult and pediatric nephrologists need to begin to work together so that we can try and focus our attention on this disease and build our evidence base to improve the outcomes that we see. So that's just a short summary of the disease as it stands, and I think now I'll hand to the expert panel where we could begin the discussion focused on how adult disease might be able to learn from what we know in pediatrics or vice versa perhaps.
So thank you very much, Louise, for this outstanding lecture, and I'm sure that the discussion will be very passionate. So sorry for being late. I have a problem with my Wi-Fi access at the hospital. Today we have the pleasure to welcome various panelists who are experts in the field. Professor Rosanna Coppo, who is a pediatric nephrologist from Turin and former president of the International Pediatric Nephrology Association, and who is a well-renowned expert in the field. Dr. Emily McQuarrie from Glasgow in the UK, who is an adult nephrologist and the chair of the Scottish Renal Biopsy Registry, and Professor Jurgen Floege from Germany, who is also an adult nephrologist. And maybe we can start with Jurgen, because I heard you had other duties in a few minutes, so you may not be able to attend the whole discussion session.
Thank you. So this is a comment from an adult nephrologist. One thing before I start, you mentioned that maybe in IgA vasculitis in children, there's a particular role of oral IgA. The alternative hypothesis to that, of course, is that you have a kind of lingering disease or predisposition, and then you need just any trigger of the innate immunity that really precipitates the disease. And that could nicely explain why you have this seasonal variation. Of course, you simply have more infections in winter. And this might be a second hit in a way that in reality has little to do with the underlying condition, which makes life a little more difficult for us to interpret. Now, in terms of adult nephrology, I think the key feature or the key problem, and this will be in the revision of the guidelines, which we are just compiling, and they will be out for public review early next year. For adults, there's no universally accepted definition of IgA vasculitis. I absolutely, from experience, agree with you that mostly we see purpura and IgA. Very rare abdominal and very, very rare arthritic involvement. And the general perception seems to be that it's very much like IgA nephropathy, where the role of immunosuppression is still under review, let's say. We just presented data at the ASN Congress a few weeks ago that at least in our Stop IgA cohort, after up to 10 years of follow-up, immunosuppression essentially had zero effect on outcome. And that seems to be true for adult IgA vasculitis, at least if you look at the single controlled trial that I can remember of Evangeline Pillebou from France, where adding cyclophosphamide had absolutely no benefit for these patients and simply just added adverse events. So I would, as in IgA nephropathy, I would encourage supportive therapy. And what you haven't mentioned is blood pressure in these children. Is that ever elevated?
Rarely we see hypertension. Sometimes in the very first 24 hours we see hypertension, but that's usually in an emergency setting, etc., etc. But rarely. I think with significant nephritic syndrome, sometimes they do, but that's an unusual presentation in the children.
Okay.
So there's interesting differences, clearly.
Yeah, and the revised guidelines will say if it's really bad, use steroids, low level of evidence. And the revised guidelines will be even more reluctant on recommending in adults with IgA vasculitis, will be even more reluctant to to recommending anything beyond steroids. And the last comment I would like to make is that if you look at rapidly progressive IgA nephropathy, which is a really rare presentation with 50% crescents or whatever, you have a large series from Beijing where adding immunosuppression after 2 or 3 years did not at all affect outcome. It was dismal in all cases, just like you say. So we probably need better approaches than immunosuppression. And I think complement inhibition is a very promising thing. And we clearly need trials in that area. fully agree with your emphasis that we need better trial networks on this disease.
Yeah, I agree. Do you think there's differences in the spontaneous resolution? We see a lot of that in children. Perhaps there's more chronicity in the adults on the biopsy, whereas in the children we do see that some of them, even with very severe nephritis, just spontaneously seem to get better. And we think the drugs have perhaps made them better, but maybe it's just spontaneous and their immune system has, you know, corrected something.
Well, children usually don't have the add-on insults. For example, a typical question I get is patients coming for second opinion asking me, should I get steroids for my IgA nephropathy? I still have 3 grams proteinuria. And when they walk into my door, they are fairly obese. What is the likelihood you cure obesity with a steroid? And I recommend weight loss, and they hate me.
Yeah, I think sometimes, yeah. Go on, Olivia.
I think I really agree with you, Louise, that the thing is probably the children IgA nephropathy is not completely the same as adult nephropathy, and the most different feature is that we have a lot of very active lesions on the kidney biopsy as opposed to more chronic lesions in most adult patients. And of course, we won't treat chronic lesions with immunosuppressive therapy and even with steroids, but when we see very proliferative lesions with crescents or even endocapillary and mesangial proliferation, even if we have not a lot of evidence, we are urged to give some kind of immunosuppressive drugs and in particular steroids. And the other point about that is that in most series, even if they are small series and retrospective, a short steroid therapy does not have a lot of adverse events in children, as opposed to the adverse events we see in adults with a high blood pressure and obesity and so on. And so I think really we have to differentiate the management of these patients.
I agree.
I have, this is Ali Poyenme. I have one question to both Louise, you and the panelist. One point often raised is that the clinical trials may not show the efficacy we hope to see because not all IgA is created equal and we put all these patients in the same basket, and whether HSP is a completely different disease or a continuum of the same disease. Somehow we have a sense collectively that we are yet incapable of classifying this disease accurately in the sense of predicting treatment response. In the same line, also like more a basic science or mechanistic question by Dr. Richard Glassick here in the chat, asking that, well, in IgA nephropathy, we have the autoantibody to galactose deficient IgA. Is there any difference in the IgA isotype or in the autoantibodies in IgA vasculitis? Is there? Do we see those molecular pattern emerge?
It's a really good question, and that's something we've just set up the IgA vasculitis study here, where we're collecting serial biological samples in patients and looking at through mass spectrometry the exact immunoglobulin A glycosylation profile in the children, and we're planning to compare that to IgA nephropathy. But at the moment, that's unknown. The small amounts of biology that's out there suggest that it's very similar to IgA nephropathy, but we don't know the precise differences and whether those perhaps who have a renal phenotype have a slightly different glycosylation pattern to those who are never going to get any renal involvement. And we see some children with very severe Henoch Schoenline Purpura where they might have GI bleeding, but yet they don't have any renal involvement at all, and we don't understand the different phenotypes in the disease. So it's something that we are evaluating, but I think remains unknown if the others agree with that.
Thank you very much. Maybe before giving the audience the question, maybe we can ask Professor Rosanna Coppo if she wants to comment on Louise's lecture.
Yeah, thank you very much. Well, I think that a relevant point indeed is to talk a bit about the differences in the pathogenesis or the biomarkers in the two diseases, because the severity of progression in children and in adults is so striking that we think that there are two different diseases, and we look at the biomarkers reported by the literature. But indeed, as far as I remember, there are several pathogenetic events, biomarkers, which are shared by IgA vasculitis and IgA nephropathy, and children and adults as well, because the point also is different between children and adults. For instance, galactose-deficient IgA1 was reported by Novak and Christoph Kirillov to be highly deglycosylated in children with Henoch Schoenline Purpura as well as in adults, and there is an inherited trait. Indeed, also relatives of these children have high levels of degalactosylated IgA1, exactly as it happens for primary IgA nephropathy. The deposits are IgA1, and it was tested by the new monoclonal antibody KM55. They are exactly the same in primary IgA nephropathy and in IgA vasculitis. We detected the high levels of IgA immune complexes in both diseases and in adults and children as well. And coming back to the dimension of the original focus, I think that there are several data from the literature suggesting that the gut-kidney axis is working in IgA vasculitis in children and adults, as well as in primary IgA nephropathy. There were seminal works from Jean-Claude Darvin, which was a true expert in Henoch Schoenline Purpura, of an increased intestinal permeability in children with Henoch Schoenline Purpura, similar to children with primary IgA nephropathy. And also Judy Nagy and other people in the past, they reported high level of IgA directed against alimentary antigens in both adults and children, and in both diseases, in primary IgA nephropathy and IgA vasculitis. So I'm not sure that there is a clear-cut different origin of the altered mucosal immunity. One is ENT, IgA vasculitis, and the other is gut, and this is IgA nephropathy. In my opinion, both may be involved, and anyway, for what is concerned the gut-kidney axis, I would bet that it is anyway a source of galactose-deficient IgA1 in IgA vasculitis and in children as well. So the idea of approaching, because Jurgen mentioned the idea of approaching the use of target release formulation of budesonide is not serious idea, also for children with Henoch Schoenline Purpura. The point is to select the correct target anyway. But the other point I would like to mention, you mentioned before as well, is the possible difference between Henoch Schoenline Purpura and IgA nephropathy for what is concerning the factor inducing the endocapillary hypercellularity and crescents, which are the hallmarks of IgA vasculitis. I mean, probably an increased complement activation. Complement is activated in a subliminal way in both primary IgA nephropathy and IgA vasculitis, but a little bit more in IgA vasculitis. And among the risk factors predicting the development of renal damage in IgA vasculitis, the low levels have been particularly stressed in an Asian group. Anyway, we did some work in the past, and indeed some work are still ongoing, on the possibility that this abnormally glycosylated IgA1 in IgA vasculitis carries some particular properties which in some way favor the direct binding to endothelial cells, like antibodies against endothelial cells, or simply as IgA, which in some way has an increased binding to these cells because of the electrical charge of the glycosylation composition, in the past, we tested the IgA reactivity with neutrophil extracts, and we published it in NDT in 1997. And there is an increased binding of sera from patients with IgA vasculitis to neutrophil extracts and to MPO, which is not a true antigen-antibody reaction, but it's more likely to be a sugar interaction, like a lectinic interaction, since the incubation with sugars decrease this binding. So my comment is that probably the disease has the same pathogenesis, which is in large part still unknown, but what characterizes this kind of particular IgA nephropathy is the reactivity of this aberrant glycosylation to endothelial cells, or perhaps also to polymorphonucleate. So in this case, there is a larger complement activation, the endothelial damage, tough necrosis, the activation of the complement, the coagulation cascade, fibrin pathway activation, and that can be the final difference. But anyway, in my opinion, the original pathogenesis is not different, very different from the two diseases and from children and adults. What do you think, Jurgen, about that, or Olivia?
Louise, do you want to comment on that?
I just agree entirely, really. Interested in Rosanna's views on the adult practice, in that they think it should be treated without immunosuppression, and what her feeling is from a pediatric viewpoint.
Indeed, this makes the difference, because I had the chance to follow adult patients for 10 years, and then for 25 years children. So I had experience with both kinds of disease, and from the clinical point of view, it is really different, because for adult patients, as Jurgen mentioned before, we have two typical cases. The most typical is a case with an acute vasculitis feature, and as suggested by Kay Digo, when presence are high, this is not very different from other patients with other systemic vasculitis as ANCA-mediated. Or patients with such a chronic kind of IgA nephropathy, which in some way has some purpura in the past, but has a slowly progressive disease. This is why Kay Digo focused on these two kinds of presentation: rapidly progressive or very active one, or very quiet and slowly progressive disease. In children, it is completely different. The disease is often self-limited, can improve, can recover, and indeed only a minority of cases have a progression. And it is true that in the last 20 years, the number of children reaching end-stage renal disease and need of dialysis in the most relevant centers in Europe is almost zero, because they were treated efficiently without any delay. And this is good, obviously. That means that we need something as pediatric nephrologists. We appreciate that the delayed treatment can be harmful, and of course there is a risk of over-treatment in some cases, and we have to discuss it. But anyway, we cannot accept the Kay Digo guideline for as were in 2012, because the effect of delayed treatment has been reported by so many authors that I think it is for sure.
So about this delay, would you recommend to wait for 1 month with significant proteinuria before doing the biopsy? Or would you do it earlier, especially in case of overt nephrotic syndrome or acute kidney injury?
Well, it is case by case. I think that each case should have a risk assessment, and you have to consider. In general, waiting for a couple of weeks or 4 weeks, if the case is not terrific, can be good. But anyway, waiting for steroids for 4 weeks may be too long. So in some cases, I see from the clinical practice, at least in Italy, I think that in other countries as well, children receive some steroids for the initial weeks before 1 month, and they underwent a renal biopsy only in case of persistent significant disease, which is a mess because you do not have baseline data. But in some cases, this is the way. So I think that anyway, it's not bad what the sharing initiatives suggest to do. Yeah.
So there is a very passionate discussion of the panelists about rituximab, but first I want to ask Emily McQuarrie if she wants to comment on the discussion, and then we'll ask the panelists their questions.
Yeah, thank you, Olivia. That was a great talk, Louise. I think from the adult nephrologist perspective, it is a very rare condition. I think as you highlighted in your presentation, we see other forms of vasculitis much more commonly. And certainly in Scotland, we have a nationwide biopsy registry. And over the last 5 years, you'd be 5 times more likely to be diagnosed with microscopic polyangiitis than you would with Henoch Schoenline Purpura on biopsy. And so I think adult contribution to clinical trials will be challenging. And so I would welcome the pediatric route from that. Certainly from our perspective, the biopsy indications we would tend to observe to ascertain if the patient's going to spontaneously remit, but there are cases in whom we would just proceed directly if they have, active nephritic syndrome, acute kidney injury, and I'm interested to hear about potential change to the KDIGO guidelines as it would be standard practice to assess patients with steroids if they have active crescentic disease on biopsy. It would be difficult to stand by and not do that in the absence of clinical randomized evidence that they're not useful. I find the scoring system of interest. The pediatric scoring system doesn't have a huge degree of granularity. It's just presence or absence of crescents. Our renal pathologist in our unit tends to also report the MEST-C scoring system, which for adults obviously gives more information in terms of sclerosis and sort of degree of chronicity, also look at arteriosclerosis and other features that are all going to have an impact on what sort of prognosis you expect for the patient, whether or not they're going to be likely to respond to immunosuppression. And obviously from a pathologist point of view, it's difficult for them to tell any difference on biopsy whether or not the patient has IgA or HSP if they're not looking after the patient directly. I was quite interested actually, just briefly, with the dental involvement in children and whether or not you actually do anything about that and involve dentists. Is there any evidence that addressing poor dentition in children reduces relapses? So it was quite striking that 70%, 50 to 70% have periodontitis. Louise, do you?
So at the moment, with regards to ENT dental type stuff, we don't actively do anything. There are studies where they've looked very aggressively at tonsillectomy and oral hygiene and showing that you can reduce the disease. But again, there's a lot of spontaneous resolution in this disease anyway. With regards to the testicular involvement, some patients do get short courses of steroids. And when we looked at the UK data, looking particularly at the renal involvement, we also looked at who'd received earlier treatment. And there were a number of boys who'd had short courses of steroids for the testicular inflammation. But again, whether we prescribe that because we feel it makes us feel better and they're going to get better anyway, we just don't really know that. Just to pick up on the common theme that people have talked about is the biopsy criteria. When we met at this international workshop in October, there was 10 international pediatric nephrologists, and we actually adapted the share criteria, and we're going to try and publish them at the moment, where we included nephrotic syndrome as an absolute indication and also an impaired GFR, but in a form of kind of acute kidney injury, which we're all becoming more familiar with classifying things. So that is in progress, and we felt that that refined them really, that the SHARE group had made a really good start to it, but actually it needed interpreting in a kind of nephrologist's view. And so we have adapted them slightly to include those patients that we do get concerned about, such as those with nephrotic syndrome. So hopefully that will come soon, and we've done that in a letter to editor in response to the SHARE group as a collaborative effort.
Yeah, that's great. The other thing is that we do often get referred these patients from, it's usually from dermatology, with their rash and their urinary abnormalities. And when the urinary abnormality is received, we tend to discharge them at 6 months, which mirrors your policy and practice. But we do then often ask for ongoing primary care follow-up in terms of renal function, blood pressure monitoring and urinalysis, perhaps annually, as there is obviously a recognised increased risk in the longer term of CKD for these patients, particularly if they're older. And if they have relapses, we would obviously see them back. But they are a group that does make me a bit uneasy because you know, the long-term prognosis is fairly variable.
Yeah.
But we would tend to use ACE inhibitors and otherwise if they have proteinuria.
May I
So then,
comment?
in the next 5 minutes or so, maybe we can take the questions from the audience. So the first one was from Dr. Richard Glassock, who said that azathioprine is not recommended for the use of primary IgA nephropathy and not effective and maybe unsafe. So why do you think it is still recommended in some guidelines?
Yeah, I don't know why indeed, because the effect in primary IgA nephropathy was nothing. Was not superior to prednisone alone. Maybe it is a long-term attitude because in the past it was used largely in children with nephrotic syndrome, in my opinion.
Because they had no other alternatives, maybe.
Yeah, yeah.
And another big discussion from Dr. Richard Glassock and Annette Bruchfield was, can you comment, Louise, on the different outcomes observed on rituximab treatment with some clinical trials showing beneficial effects and some other negative effects? So what can you comment on that, please?
I think it's very interesting. We have a disease where it's predominantly immune mediated, there's antibodies, so we think logically that B-cell depletion might work, and you have case reports of severe patients who all seem to get better when they've had multi-drug resistant or very steroid dependent disease. I think it will continue to have a role in that group of patients, but I don't know whether it would be the first drug to trial in this disease when we have hopefully complement inhibitors coming to the market, and they may be superior on the background of it being negative in IgA nephropathy. So I think it will have a role, and it's there within the literature, but it's predominantly within the literature in case reports, and there have been no big trials. But I don't know whether it will progress to trial because of that negativity and that link with IgA, assuming that they are part of the spectrum of the same disease, which we believe and have no evidence to say that they aren't a similar pathophysiology. So I think it will still have a role, but I just don't know if it will get to trial testing when we have complement inhibitors.
Yeah,
I should comment.
may make a comment.
Dr. Brooks, I think I would love to have a trial with complement inhibition, especially now after the Advocate trial is out there. But I use rituximab in severe cases only, and those are patients who you see that will end up in end-stage renal disease eventually, and we've had some positive effects, but these are really vasculitic patients and not IgA nephropathy, you know, normal patients. They are sick patients that I would use anything else, but I would love to see a complement inhibition trial, a randomized trial.
Yeah.
Dr. Brookfeld, there are currently industry-sponsored clinical trials of complement inhibitor pathways for IgAs. You know, one question: what is your definition of severe disease? So
if they have if they have multi-organ involvement, not only we've had patients with, I'm in adult nephrology that would have something else, skin or gut or something like that with bleeding, and you feel you have to do something, and then you add perhaps plasma exchange. That's kind of a difficult discussion, but some people like that. And then if we don't, you're not successful with steroids and they progress, and then it would be like any vasculitic patient. We have mostly ANCA vasculitis patients with good experience and these trials out there, but these are sick patients that you feel that if you don't do something, they will do badly. And in those patients, I feel that we've had some benefit of rituximab treatment. So I would not be against using it in sick patients, but not in the normal patients. And I would like to, we are in all the IgA nephropathy complement inhibition trials and working hard to to add patients to these trials. So, but for IgA vasculitis, if that's what we discussed, that would be very interesting, especially in the pediatric situation where you could have a lot of patients.
Mm.
There was a comment on the lack of
So
benefit.
Louise, do you want to comment on this one, or?
No, I agree entirely. I think the clear path really will be complement inhibitors, and in the pediatric population it would be great, but again we have to balance that with, you know, significant biological intervention in a population who may get better, and it's perhaps we need better ways to triage the patients, and that might be better biomarkers to be able to discover which ones are going to have a more severe renal course. And at the moment we don't have anything robust enough to predict those patients, but I think it's the logical next step is complement inhibition in this group.
Okay, so I'm sorry.
I think we are losing Olivia due to some Wi-Fi issues she may be having. So while we wait for her connection to bounce back and perhaps wrap it up for us, I have one question to Louise and the panelists. The patient I struggle the most with are these frequent relapsing HSP patients. They come in with recurrent rashes, and at some point the creatinine keeps creeping up and going up. So how do we handle those?
I don't know either, and they're sat in clinic monitoring them, and sometimes there's nothing in the urine and then the next minute they surprise you and there's proteinuria, and they're probably similar to some of the adult ones where there's a more chronic grumbling disease, and then we see more chronicity on the biopsy. But at the moment we don't know whether they're the group that should be on ACE inhibitors earlier on. We don't know, but the numbers are fairly small, and we don't really have a good grasp on those with recurrent disease, because I suspect our general pediatric colleagues are looking after many of these patients, and they don't really reach our practice until they get significant renal involvement. So I think until we get a good handle on how many patients there are, and considering different ways to target them, we don't know. But again, they're a group that I worry about, because I think they probably run a more chronic grumbling course that may be more damaging than some of the acute inflammatory presentations.
I had one of these cases. Can you hear me?
Yeah.
Yes.
I had indeed in the past one of these cases. She was a girl, a 18-year-old, with a kind of recurrent disease. And at the time, we repeated plasmapheresis session for 3-4 times over 1 year. And there was a temporary improvement after 10 sessions, and then again a relapse. In the end, she reached end-stage renal failure. They are very, very severe cases, and I agree this is difficult. I think that those cases should be the ideal target for anti-complement treatment. Because I think that there is something different in these malign, in these severe cases. And I think that targeting complement in this case should be a good opportunity.
Ali, is there any other question from the audience, because I've lost them all?
No, I think there have been discussions and questions, but I think we covered them most. Dr. Aurora was just the latest asking about the utility of mycophenolate as a steroid-sparing adjunct in this class of patient, or in which class of the patient.
I think it's within that group where you feel that you should be immunosuppressing them, then at the moment it's open as to which immunosuppressive agent that you would use. Mycophenolate is consistently on recommendations, and there are reports. It's a drug that we're very familiar with, and it may have some steroid-sparing properties, but we don't really know that. We don't know whether the majority of the effect is steroid when we're using them, because most of the treatments are used in combinations with steroids. But there's just so many unknowns that we don't know what agent is best, and that's what we're trying to plan on an international basis, is to compare a lot of the standard management that we have, so then we've got a platform to be able to compare the more novel treatments such as complement inhibitors, because we don't have a standard management for this disease at all, even within institutions, but across countries, and let alone across the world. And I think that's what we need, is a standard management, or one or two standard managements, that we can then open up industry trials and be able to explore novel treatments that might be better and produce better long-term renal outcomes.
Often feels, and perhaps now in IgA and HSP in the adult patient population, I have to say, but also in GN in general, that immunosuppressants are our antibiotics. The patient we give it to them, they feel good, we assume it worked, but we will never know whether it was just the viral syndrome or real bacteria where it was indicated. So it's yeah, okay. Olivia, any more?
I agree, but I thank you for this moderators also, and see you soon for the next question. Okay.
Thank you.
Thank you.
Barely can understand you. Okay, but
so thank you very much, everybody, and see you soon.
Thank you. Bye.